Hello guys, we have a question from MRCP step 2 that brought to you. The question is about a 15-year-old female with right upper quadrant abdominal pain. She had a history of sickle cell anemia and several admissions because of hand-foot crisis. During the last two admissions, she complained of abdominal pain. Okay, so this is and emphasize about this pain in this patient. She had a slightly fever, mildly jaundiced, and a little tachycardic, and stable blood pressure, and there's a dullness in percussion of right lung, and a tenderness in the right upper quadrant. And the liver is a little larger and 3 centimeters below the costal margins. You can see here the severe anemia, hemoglobin is 6, and high white PCs, platelet is okay, and the UA was normal. AST is slightly elevated, and didn't mention about ALT. Alkaline is okay, but it didn't um, exclude the cholestasis in the patient. The albumin is slightly reduced, and you can see urine osmolality is really reduced, okay, and we can see urobilinogen 3 plus in the urine. Blood protein and bilirubin itself is 0. In chest x-ray, she had opacification in the right upper zone. So the questions are, what is the cause of the abdominal pain? What do you think? And what investigation would you request? I think she had an acute cholecystitis, because in these patients we can see pigmented stones in the gallstone due to the chronic hemolysis. So what should we do? We should do an ultrasound of liver and gallstone. What's the cause of the girl's respiratory and chest X-ray findings? In these patients, in this age, maybe she is hypo or splenic person, so capsulated organisms are can be the causes of infections like pneumonia. Okay, let's see here. Yes, streptococcal pneumonia in this patient is most probable cause, and other capsulated organisms can be Neisseria meningitis, Haemophilus influenza. The other diagnosis can be differential diagnosis, can be pulmonary infarction, also can cause its shadowing in this patient, but it's less likely, especially in the absence of pleurisy, and severe breathlessness. We didn't have, they didn't mention that, okay? And about the uh, fourth question, the chronic tubulointerstitial nephritis or renal papillary necrosis can impair the concentration ability of the kidney. So we see this low urine osmolality, okay? And let's review some other details. It's an autosomal recessive disease because of the change in glutamine by valine. We have other crises like hemolytic crisis, aplastic crisis, sequestration crisis. Sequestration crisis can be fatal, usually occur in younger patients, and the precipitating factors for cycling include hypoxia, infection, dehydration, and pain.